Okay, so now without further ado, I'll just move to our next session for today, that is on post-endo restoration by Dr. Priya Jain ma'am. It is my immense pleasure to welcome our next speaker, that is Dr. Priya Jain ma'am, which is a highly accomplished endodontist and a gold medalist from Sharda University, class of 2022. Ma'am is a private clinician in the heart of Delhi and serves as an endodontic consultant across multiple setups. Her commitment to advance-based dentistry ensures that every procedure is backed up by latest research and best clinical practices. With a passion for restoring functions and confidence, ma'am believes that endodontic goes beyond saving teeth. And please join me in welcoming Dr. Priya ma'am and to share her expertise on post-endo restoration. Ma'am, please start with your presentation.
Thank you, Vishakha. Thank you so much for your great introduction. I hope I'm audible.
Thank you, ma'am. Yes, ma'am, you're audible.
Yeah. So, hello everyone. A very good morning to all of you. I know it's a big day. We are having a clash finals with New Zealand. The India is clashing with the New Zealand today. So yes, it is a big day for all of us, and it is a big day for me as well for presenting a topic in front of you. So I know it's a Sunday morning and everybody is in their beds, very lazy, don't want to hear anything and don't want to study or something. So before starting my treatment, let me ask you all. How's the Josh? I would be needing everybody to be active and reply in the chat box so that it can be interactive a little bit. So, yeah, how's the Josh? Okay, I hope it is high for everybody because I am very excited to talk about this topic that is post endodontic restorations. So, whenever a tooth comes to us, we are doing a good diagnosis, and then our next step is to do a root canal therapy. We are sure we are gonna do a good root canal therapy, and we did a good job by doing it. But what is the next step? What after doing a very good and very good in terms, I would say, like good irrigation, good seal, everything is looking good in the x-ray. But what is next? The next thing is to make sure that the tooth we treated stays there for a longer time, it is functional, and the patient is satisfied. So by doing a root canal, by doing a mere root canal does not solve your problem. We have to seal the success properly and indefinitely. So, doing a root canal treatment or doing a root canal therapy is just a half done battle. So, how can we seal this success? So, everybody, I hope you are able to look at the screen. I have given an X-ray, and I would want you people to tell me what is wrong with this X-ray or what is wrong with the treatment that has been done in this X-ray. I'll be waiting for your answers. Anybody, anything will work. What is wrong with this treatment that has been done in this X-ray? Okay, short obturation, Dr. Malika. Anybody else? You can open your voice notes as well. I have no problem. Either you can write in the chat box. Anybody else apart from short obturation? Okay. So, yeah, short obturation, the working length has not been achieved in the mesial as well as the distal canals. There is a root resorption, yes, and the periapical infection is there. But what I need you to also look about this coronal leakage that is happening. We are all are so focused on seeing that periapical changes, that apical changes, that we actually overlook our marginal seal. If we do not have a good marginal seal, everything is in vain. Let's go to another X-ray. So yes, this is a case of radix endomalaris, and it has the same problem. The working length is short here, the working length is short here. It has not been determined, but that is not our problem. Other root is our problem, in which we have not achieved the working length properly, and the periapical lucency develops. But what is there to be assessed also is the crown margin, the restorative margin. It has been decayed. You can see the material is there, but the decay has not stopped. It has progressed only. And why is it happening? Because whenever we are restoring the tooth, we are not removing the whole caries, which is bad. The carious process won't stop by doing a mere RCT. Let me make you understand that thing. If you're not doing a proper restoration, if you're not removing the caries will take all the material of the tooth that is available in the tooth. All the good dentine it is going to take. Now, next picture. So this is a radiograph that has been taken yesterday for my friend, and I know the palatal canal is not visible, but you can see the sealer puff. Okay, you can see MB1, MB2 detected. Everything is good. Everything is right in its place. And this RCT was done 5 years ago. So if the sealer is there, everything is intact in the apical portion. What has gone wrong? The wrong thing that has happened is this ill-fitted crown. This ill-fitted crown is not only leaking from the distal side and destroying the integrity of this tooth, but also is destroying this tooth. There is food lodgement here now. And what is happening is the caries process has reached to our pulp. And when I did the cold test yesterday, it is non-vital. Now I have to do the root canal for this tooth as well. So whenever you are planning for a treatment, whenever you are planning to do any kind of treatment, please plan it from the first. You need to know what are you going to do, and what are you doing? Are you doing right or wrong? Because a smallest of your mistake can lead to this. This brings me to your study, to a study which has been done by Ray and Trope in 1995 only, in which they have said if we are doing a good quality of endodontic treatment, that is, if we are doing a good RCT, if we are doing a good restoration, the success of the treatment is 91.4. But even if we are doing a good RCT, with good sealer, with good irrigation, with good everything, but we are not concentrating on our coronal restoration, the success will go down to 44.1%. Whereas if we are not doing good RCT, but we are sealing it, we are isolating it from the oral environment by giving a good coronal restoration, the success rate is 67.7%, which is more greater than the cases that has poor coronal restoration. So you need to understand that doing good root canal is not the only thing to achieve your success. This brings me to one more X-ray. So when I was making this lecture, I came across this X-ray from the net only. So what has been done, the working length has been achieved, the material is properly sealed, the canals are properly sealed, there is a good coronal restoration as well. Everything is well. Then nothing will happen to this tooth. But after 2 months, this comes as a fracture. Now, why does this happen? Okay, we'll say that root canal, whenever we are doing a root canal, the tooth becomes brittle. It loses moisture. हम क्या कहते हैं कि अरे फ्रैक्चर इसलिए हो गया है क्योंकि क्या होता है जब हम रूट कैनाल करते हैं तो हमारा जो टूथ है वो ब्रिटल हो जाता है. एंड व्हाट इज ब्रिटल? इट लूजेस इट्स मॉइस्चर. But you need to understand that our tooth does not become brittle. You can see in this study, which was done by Perroz et al. In 2008 only, that he did an extensive research and he stated that there are no or very minimal changes in the dentine structure, which is there in vital tooth and in the root canal treated tooth. So there is no such big difference. So why are we having this fracture? Why is this thing happening to us? It is because we are doing large taper shaping. Like Dr. Anu said, large shaping does not help your irrigation. You have to do preparation in a minimal way, but you have to do your cleaning part very well. Also, using a lot of chelators, your EDTA gels, using them again and again, you are just making your dentine erode and you are making the tooth weak. But let me bring your attention to the first and foremost reason. Why is our tooth is fracturing? मैंने चलो 4% 6% अच्छी मैंने वो कर ली, उसके बाद भी माई टूथ इज फ्रैक्चरिंग. वाई? The biggest reason and the main reason is the reduction in the level of proprioception. Now, what do I mean by reduction in the level of proprioception? That is, whenever we have a vital tooth, there are innovations, there are vasculatures that are present that is giving the response to the tooth, whatever is happening to it. अगर हमें कोल्ड फील होता है तो वो हमें पल्प बताता है, हमें हॉट फील होता है वो हमें पल्प बताता है. If we are addressing a lot of load, that response will also be given by the pulp. So let me give you an example and make you understand this concept more vividly. That is, okay, I would like to know by everybody, which is more stronger, a rod or a pipe? A rod or a pipe of same mass and same material, which is more stronger? I'll give you 1 minute and just let me know which is more stronger to you. Okay, we'll wait for 5 more seconds. Okay, rod, ठीक है. Okay, fine. Rod, yes, okay. So all the people who are saying rod are absolutely wrong. So this is not what I am saying. This is what Google also says. So I did a research on, like I searched in the Google bar as well, which is more stronger, a rod or a hollow pipe. It is stopped working. Okay, which is more strong, rod versus pipe? So even the Google Baba said a hollow pipe has a higher strength to weight ratio than a solid rod. What does this mean? Your rod is less stronger than your hollow pipe. Let me bring you attention to your hand. So हमारी जो hand की bone होती है, is it a solid rod or it is hollow? It is hollow. It has a bone marrow, it has innovations in it, and still it does not fracture very easily. ऐसा नहीं है कि मेरा अभी यहाँ पे धक्का लगा and it fractures. It does not fracture like that. It has strength in it. Similarly, our God has made our teeth like that. Our vital teeth act as a hollow pipe. It has innovations, it has musculature. It gives us the response कि नहीं मुझसे अब लोड नहीं लिया जा रहा है. I have hot sensation, I have cold sensation. But whenever we are doing a RCT because of any reason, that is a carious process or maybe for any biomechanical factor, we are weakening the tooth and we are making the root canal treated tooth in a solid rod, and that solid rod can fracture very easily. So yeah, we need to make a decision about it. What do we do after the root canal therapy has been done? Half a battle, we have won. Very nice, congratulations. But let's get to the real life. The patient does not want how better or how nicely you have done your root canal therapy. They want you to save their tooth. They want them to having asymptomatic food chewing. They want I can chew fruit from this. The tooth that is looking is aesthetic. It does not disintegrate in an year or so. You have to make that decision. And how can you make a decision? So this was a very good quote that I came across a while ago, and that is what I try to inculcate. I have tried to inculcate in this PPT as well as what I am doing in my day to day life at Apna Dentist. So yeah. Mm. Let me show you what we are doing. So we are not jumping into a treatment right away. That this is the tooth, I'm gonna do root canal for it, I'm gonna do vital pulp therapy for it, I'm gonna do restoration for it. I need to assess everything. I need to do those tests that Dr. Sarita has told. I need to tell the patient that these are the problems that you have, and only just not only your root canal is gonna solve your problem. You have to do these things. I know patient can be fussy, and you are not able to tell them a lot of things so that he or she does not run away, but you have to tell them that this problem is there. I'm going to start with this thing, then we'll take the control, then we'll see. Because the thing is, if you're not doing correct justice to the patient, to the tooth, you're not doing correct justice to your profession. You have to take care of all the needs that that particular one tooth needs. So yeah, that's what we are doing at Apna Dentist. We have a good team of doctors, and the main pillars are right now myself, Dr. Priya, Dr. Jayati, who is working very closely to me and under the rubber dam, which makes me so happy because you are working as an endodontist, but somebody who is working closely is evenly working with you is a bliss. And then Dr. Abhishek, he works very much on the treatment and right from the start. We make extensive treatment plans for the patients. He takes care of the aesthetic and the implant part. But and we actually try to do good dentistry, just that. I know it's very difficult to do in such a competitive world, but if you do and if you're persistent, I think you can do very well in your future. Because the thing is, you are doing it for yourself. You're not doing it for somebody else. So here are for a few of my cases. I am a big fan of doing restorations. In my PG, restorations were a headache to me. But then cut to rubber dam was a headache to me. Let me tell you, after doing even 3 years of PG, rubber dam was a headache to me. But then practice makes the mind perfect. The thing you do daily comes very easily to you. So start doing one thing daily and it will come easy to you. And then you can take upon something new. So these are a few of my cases. I love doing multiple rubber dam isolations. I am a fan of vital pulse therapy. I just did a like you just attended a lecture from Dr. Lakshmi, how she talked about regenerative, and regenerative is not just open apex. It is vital pulse therapy, which is in, and regenerative is not new. I'm sorry to contradict Dr. Lakshmi, but regenerative is nothing new. It has been there. The subjects has been there from 20, 25 years, 30 years. And now we are doing vital pulse therapy in a more predictable way. And I'm very happy to do it. So I did it for a kid. He was asymptomatic and I was happy. Not let's deviate from our topic. Let's come to the decision making that we are going to do today. So start from the start. You have to be active about your decisions. You have to not be laid back कि चलो अब मैंने आरसीटी कर लिया अब पहले मैं आरसीटी कर लूं पहले मैं पेशेंट बना लूं मैं फिर देखूं या फिर देखूंगा कि क्या करना है नहीं at least if you're not telling it to the patient you should have it in your mind what is your treatment plan. So you have to be proactive from the first. You have to begin with the end in the mind and how you can by assessing the restorability of the tooth. So you have a tooth which has come with the endodontic treatment done only. There is a poor root canal filling. You can see, like I have showed you the X-rays. All those X-rays were the X-rays that I have done retreatment for. Okay, so there was a poor root canal filling. The working length has been not been achieved. There is a periapical infection. Okay, so this is not my topic to talk about. Like, and I really want to talk about it. The periapical radiolucency that we are all so astonished about. Let me tell you, every periapical radiolucency is not infected one. So we are taking an X-ray, there is a periapical lesion, and we are like, okay, cut. We'll do a root canal for it. We'll do a surgery for it. But what we need to understand is every periapical radiolucency is not infected. It can be a healing one as well. So how can we differentiate? We can differentiate by looking at the past X-rays. Like what happened with me, I'm a consultant endodontist as well. So I went to one of my clinician friends and he asked me to do a root canal for a patient. Yes, the distal canal was short of working length and the patient was having pain, but her pain was because of food lodgement and not because of that short obturation. Listen to me. It is not because of that short obturation. How did I know? I took an X-ray. I saw a periapical radiolucency, which is 2 to 3 millimeter in diameter. Then I asked my clinician, do you have a previous X-ray? So he has done this root canal 2 years ago, and he was like, maybe there is a problem because the distal canal is 2 mm short, just 2 mm. So I asked him, please show me your X-ray, previous X-ray. I looked at the X-ray and I saw that the radiolucency when my doctor treated it was at least 5 to 6 millimeter in diameter. So it has been reduced. It is a healing periapical radiolucency. So please don't get very excited. Okay, मेरे को periapical radiolucency दिखी. I'll call an endodontist. I'll get a root canal done. I'll go for a surgery. No, you need to assess. You can assess it with past X-rays. If you don't have past X-rays, please take a detailed history. हम बार बार emphasize कर रहे हैं, Dr. Manisha has emphasized yesterday, Dr. Sarita has already emphasized, please take a detailed history. A detailed history can make your life. Not just because what I'm telling you, because if a patient has is a bruxer and he's not telling you, and you're not overlooking signs as well, but if you'll talk to him, he'll tell you, no, I eat this, I eat that, मेरे को रात में पेन होता है. He'll tell you things that you are not able to see or detect, and then you can make your treatment plan more better. So please assess those restorability factors. Now coming to assessment, obviously yes, assess the poor root canal filling. Then look for active inflammation, that is if there are signs and symptoms that is present to root canal. Pressure sensitivity, if the patient is not able to chew from that side, please understand that thing. There is something lacking. Please don't tell कि हाँ 2 दिन में चला जाएगा, या you will give an analgesic and anti-inflammatory and it will go away. No, it will go not. Unless and until you make a permanent solution of it. Then exudate fistula. Yes, this is a very good indicator that your root canal is failing or you have a periodontal problem, because there will be a sinus tract draining. And there are a lot of factors also, but the biggest factor that I want to bring in attention to everybody is the periodontal disease. So whenever we are looking at tooth, we always overlook the periodontal signs, and I'm very sorry for that. Even I used to overlook that, but then it gave me a lot of problems, because I have done a very good job at our city, and the patient is still saying I'm not able to chew because I think the my tooth is moving. And then I saw, oh my god, there is a pocket, 6 pocket, 7 pocket, that I have not seen before. I have not told the patient as well. I'm ready for to give the crown to the patient, but how can I give when the periodontal is so weak? I'll remove more of the structure and back to square one. We are making the tooth weak. So you need to look for those periodontal factors. So yes, please, in your PMT, please keep a Williams probe as well or a pocket probe as well to assess the pockets, so that you can know how much periodontal intervention do you need. Maybe a scaling or curettage will solve your problem, but you need to assess that thing very well. The other factors that you need to understand is a medical condition. I'll talk about the biomechanical factors after the medical condition. So, what is happening in the medical condition? If the person is on some kind of chemotherapy, he's not able to maintain his oral hygiene. So, you need to understand what kind of restoration you have to give him. अगर तुम direct restoration के लिए जाते हो, patient is not maintaining its oral hygiene, then the direct restoration will fail, because all we need is a good oral hygiene in that. If the patient has some inflammatory disease, the patient would not be able to appreciate good PFM crowns or good zirconia crowns. So you have to plan it accordingly. Now coming to the biomechanical factors, you have to assess the biomechanical factors like the amount of tooth structure that has already been removed after the caries removal. Not you have removed because of your preparation, but the caries have already done the destruction. The anatomical position of the tooth, whether it is posterior, whether it is interior, because the loads that are faced by posterior and interior tooth are very different. But that is what we are going to talk about later on. The functional load that is the tooth having. Like I said, if the patient is a bruxer, the load will be more. If the patient is a tobacco chewer, the load will be more in comparison to the normal tooth, normal person. And the aesthetic requirement of the tooth. Whether you are giving a restoration that is coming into the smile is looking better or not. You need to make those kind of decisions. So yeah, begin with the end in mind whenever you are thinking of doing a treatment, any kind of treatment, whether it is filling or whether it is restoration. Coming to first things first, so I know Dr. Anu and Dr. Manisha has already talked about pre-endodontic restorations, and all the people in the audience, 50% of them must be thinking, so what, we'll do the rest, we do our cases like that only. What is the need of doing pre-endodontic restoration? The people who are doing rubber dam, and even if they are creating a barrier with a liquid dam, are much better. But you need to understand that is not the absolute solution. You need to have a you need to have a pre-endodontic build-up before you start your case. And why is that? The thing is, look at this tooth. Okay, so it has a caries, a V-shaped caries already. Whenever you're gonna make your endodontic axis, you're gonna make it in this way. Okay, So now your this tooth structure is also lost. What you have is one marginal ridge and two cusp, which will bear a lot of load in the inter appointments. Now people will say, "Arey ma'am, it's okay. We'll do an occlusal reduction, and reduction when the crown is not will be in contact, our problem is solved." Listen to me, friends. The thing is, you are not sure when are you going to. If you're an endodontist, yes, you are going to complete in single sitting, in double sitting, in a week, maybe. But you need to understand the thing is, whenever you are doing a root canal therapy, you never know when you are going to complete it. Maybe it's a week, maybe it's 2 week, maybe it's 3 week, maybe the patient went out of station, he's coming after 2 months. So you never know. And what is happening in those time is, to maintain the balance, the tooth will come into its occlusion, it will extrude out, and you will lose the clinical crown, you will lose the stability, and a lot. So what you need to do is, please assess your pockets. Please do the pre-endodontic restorations very well. Then move to your root canal therapy. It does not only makes your root canal therapy predictable, like Dr. Anu said, it creates a reservoir for your irrigants. It protects your intracanal medicaments as well. And also one more reason, like I would like to talk about, is hypochlorite reduces your bond strength of your composites with dentine. Understand this thing. Okay. So whenever we are using a lot of hypo, and then after we are restoring it, our bond strength is already weakened. So the marginal integrity has more chances of disintegration. So yeah, please do the pre-endodontic restoration in the first, so that you don't have to deal with this. We can overcome this by applying chlorhexidine, by applying antioxidants, and then we can go about it. But why do we have to make so much of efforts when we can do the pre-endodontic treatment in the first basis? Okay. As I said, it makes your root canal therapy predictable. It provides you a high bond strength. It prevents fracture in your inter appointments. It improves aesthetics. The patient is not worrying कि मेरा food lodgement हो रहा है. There is a white thing that is visible, because the white thing that is visible is very small. And the for first and foremost function of this pre-endodontic restoration is reinforcing the pillar of post-endodontic restoration. And what is that? Four walls of the tooth. If you have four walls of the tooth, you now know what do you have to do after. If you don't have those four walls, you are not predicting what I am gonna do. You are just like, okay, this is there, I'll do a GIC, I'll do a composite, and I'll do a crown. But you don't know after effects of that. So let me give you a good example of a case that has been taken from some of my colleagues only. So this is an X-ray. Okay. In this X-ray, we have to do root canal for this one. Okay. So it has an amalgam filling. I have to remove the amalgam filling. Okay. The mesial marginal ridge is not good. So I am building this up. I'm doing a pre-endodontic restoration. But what after that? I have done my pre-endodontic restoration from mesial. Shall I jump to my root canal? No. Here, where is you have to read your X-rays very well. Can you see this distal caries as well? So you need to actually seal that distal margin as well. If you're not sealing that, your irrigants percolate kar sakte hain, and your hypoaccidents will happen, and a lot. So yeah, please do your distal pre-endodontic buildup as well. Then you can start with your root canals. That will be beneficial. Okay, now we have talked about how to assess it, how to do it. Now the biggest question is, does every endodontic teeth needs crown? So how many of you think that yes, it needs a crown? Let me know. Okay, and then we'll talk about it, whether it needs it, whether it is not. You have to understand this thing very much now. This is all what is about post endodontic restorations. If you are not uh, okay, Dr. Disha says it does not. Okay. I would like to know the reason, but yes, let's talk about why it does not need one. So this is a Coke can. I'm a big fan of Coca-Cola as well. So yeah, there is a big can of Coca-Cola. Can I destroy or crush this crown with my hand when it is intact like this? Can I crush this crown? No, I cannot. I cannot till the time I open the tin can. When I open my tin can, when I open my can opener, only then, even after the Coke is there, I can crush it now. Whether the Coke is coming or not, I can crush it. Same that is happening with our tooth. When our tooth is vital, there is no caries exposure, there is nothing. The tooth is strongly sitting in our arch. But whenever there is a caries process, whenever we are doing a filling, whenever we're doing a root canal, we are actually in some kind, we are disturbing the integrity of the tooth, and the forces that will be applied to that tooth will can lead to a fracture. I'll give you one more example. So this is Taj Mahal. Okay. This is the monument which comes in Seven Wonders of the World, and it is saying standing strong. Why? Because it actually worked on this principle. This monument has been created in a way that the layering that has been done in a horizontal pattern, so that when the forces are applied on that, it will dissipate those forces in equal manner, in uniform manner. If the vertical stacking would have been done, the pressure that had the stress that have been generated would have been at every vertical stack, like every joint of vertical stacking, and it will disintegrate it. Also, the dome that has been given to this Taj Mahal also absorbs the pressure. How? So basically, this dome has been divided into, just a second, my cursor. Okay. The dome has been divided into two parts. One is biodome, the upper one is biodome, and the lower one is biorim. This biorim is supporting this biodome, and this biodome is absorbing all the stresses and dissipating it in the uniform manner so that our foundation does not disintegrate. If it disintegrates, the forces that are applied to the biodome, the हमारा biodome हमने हटा दिया, the all forces that are subjected to would be on biorim, and already those are in tension. If we'll apply more stress, the foundation will disintegrate, the dome will disintegrate. Similarly, this biodome is applied to our tooth. So you can see this line. This line is from the height of contour, from buccal to lingual or buccal to palatal. Okay. So the area that is above the line is your biodome, and the the area which is below your line is biorim. Okay, everybody, please understand this concept because this is what everything is based on. अगर किसी को भी problem होता है of understanding, just let me know. Okay. So yeah, so, the upper portion which is acting as a biodome is mainly consisting of enamel, and the biorim is mainly consisted of dentine. So whenever the force is applied, let me go to this picture for you. So whenever the force is applied on the tooth, you can see the stress generated patterns. These are the stress generated patterns whenever we are applying some stress. So the stress that is applied in enamel is oblique, and in dentine it is horizontal. And the biggest of the stresses that has been generated is at DJ, that is the dentinal enamel junction. And where do we have our dentinal enamel junctions the thinnest? It is at the neck of the tooth. So let me bring it to you to the concept of abrasion and infraction. So we all know why abrasion happens. Abrasion happens because we are rubbing some object on our teeth and it is wearing off our enamel. But abstraction happens because of excessive or irregular load, because of which there is a wedge-shaped cavity which is happening on the neck of the tooth. The enamel wears off from the neck of the tooth. And why is it happening? Because DEJ is the thinnest in the that portion, and the stress generated is a lot at DEJ. So the response that is given by the tooth is in the form of that wedge-shaped cavity that is happening in the neck of the tooth. So you need to understand that whatever restoration you are giving should be in harmony with the should be in the harmony with the tooth, so that you do not face this problem. Now we have talked about how the stresses are working on how are the stresses working on this tooth. Now let's move. How can we select a proper restorative material? We have different cavities, class 1 to class. So this was a study that was done in which they have studied endodontically treated teeth from class 1 to class 5. The structure decreased. As the structure decreased, yes, the marginal stability is gone, the ridges are lost, and yes, the stability is reduced. So we have to assess a good appropriate material so that we can reinforce that structural integrity of the tooth. How can we do that? The selection of appropriate restoration are gonna be based on 4 C's. These 4 C's are intercuspal distance, caries, cracks, and cusp capping. Before diving into this, you need to understand that our tooth is already compromised with the root canal treatment we have done. We might not have we might not have disturbed the integrity of the tooth, but the caries process has already done the job, and we don't know in how much manner. So we need to know already there is one factor that has been ticked off, that is endodontically treated teeth. Now we have to look upon different factors. First is your intercuspal distance. So the intercuspal distance is the distance not from the this to this. It is from the buccal cusp tip to your lingual or palatal cusp tip. So whenever you are going to measure, you can measure with the help of a Williams probe or a scale, whatever you want. You need to look that there is a this is a distance from the cusp tip to the cusp tip. And whenever there is a class 1 cavity and the intercuspal distance is just 1/4 of the tooth circumference, you can go for the fracture resistance, or the amount of fracture that happens was just 11%. In these kind of restorations where there is minimal endodontic cavity, there is minimal caries exposure, you can go for a direct restoration. You no need to do anything but a beautiful biomimetic composite restoration. And how to do that biomimetic composite restoration is another webinar to talk about. But yes, you should know how to do a good, beautiful composite restoration. Beautiful does not mean good looking. Beautiful means that you are replacing the dentine with a dentine material. You are replacing the enamel with an enamel material. Okay. Even if there is 1/3 loss of ICD in class 1 cases, still you can go for a direct restoration. But if it is more than half, please go for indirect restoration, whether you're onlays, whether you're inlays, whether you're crown lays, whether you're overlays, you have to, or whether a crown, you have to go for a indirect restoration. In class 2 MO or in class 2 MODs, you can see even after 1/4 loss of ICD, you can still go with direct restoration because the fracture is not that great. Okay. But if you move to 1/3 and one half of the ICDs, you need to go for your indirect restorations. So I think now you know what is the difference when your endodontically treated teeth is there. You have made an access cavity. You need to look कि मेरा कितना distance है, मैं इसको cover up कर पाऊंगी, whether a good composite restoration, good materials that I'm using in composite can reinforce this or not. Okay. This is a study that tells you the same thing, that whenever we are doing something and doing an endodontic treatment done and the ICD is this, fracture resistance reduces very vividly from 125 to 51.2. And why is it happening? Okay. So whenever we are like we have done an endodontically treated teeth and we are making endodontic access cavity, the forces are still there and it is being dissipated to the tooth. So the cusp that is functional cusp is your cusp that comes in the contact with the tooth of opposing functional cusp, and that is the main cusp that is bearing your load of any mastication and everything. So this functional cusp will always be in tension. Okay, and your non-functional cusp is what is having your compressive stresses. So, whenever the force is applied on this tooth, the tooth will actually, with this big endodontic cavity, the tooth will try to flex and this will fall apart, leading to fracture. And how will you diagnose which tooth is in compression and which tooth is in tensile stress? What you need to do is, this is a very clinical tip. You need to take an articulating paper. Please take a standardized articulating paper. What I use is a 40 micron Bosch articulating paper. Tell the patient to bite on it, tap, 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 and see. If your marks are coming on the outer surface of the cusp is in compressive stress. That is a good stress. That means it can bear the load. But if your stress lines or your articulating lines are coming, articulated paper lines are coming on the inclines of the cusp, this is in tension, and you have to remove the tension from the cusp. Otherwise, it will fracture. So that is why the intercuspal distance is so important. Now, talking about caries. When I am talking about caries, I'm not talking about the occlusal extent, but the proximal extent. I am already done with my endodontic treatment, so I am not considered very considerate about the caries that is happening occlusally. It does not matter to me because we have already uh, uh, did our access cavity preparation occlusally. We have to look proximally how deep it is going in. Is there any enamel left for the bonding or not? Because you all know composite bonds well with dentine, well with enamel, and not with dentine. If there is no enamel left, we have to do a deep margin elevation, deep margin accusation. Then there is no point. Our tooth is already weakened from the occlusal cavity. The proximal cavity is so deep. We need to give an indirect restoration. We cannot just go with a direct restoration in these kind of cases. You have to give an inlay or an onlay. Next factor is our cracks. So cracks which are within the enamel are good cracks, are the cracks which can be saved, which we do not have to worry about. But even a millimeter of crack which is passing in the dentine, it can lead to the disintegration of the tooth. So if you have crazed lines which is in just in your enamel and it is not going into your endodontic cavity, it is not seen in your endodontic cavity. Why I'm saying endodontic cavity? Because an endodontic cavity is mostly dentine, not enamel. Listen to me. Okay, that is why. If there is no cracks or even a crazed line is not there in your endodontic cavity, you no need to do a lot of indirect restoration. A good fiber reinforced materials are there. Fiber reinforced composites are there. You can do good fiber reinforced composite restoration, and you are done to go. And you're done and good to go. But if there is a millimeter of fracture in your dentine, you need to go for indirect restorations. Like in the study, they have told the same thing. If your crack is in enamel, we no need to worry about that. But if it is internal, it is in dentine, whether it is oblique or whether it is vertical, you have to go for indirect restoration. Either we can go for a partial onlay or we can go for a full occlusal overlay. So indirect restoration is a very different part, which is very extensive. If all it required, we can keep a seminar for that as well. But let me just tell you what is onlay, what is overlay. Let me just clear the confusion. Onlay is something which is extending to your proximal box and capping one or two cusp. That is it. One or more than one cusp, you can say. Okay, but your overlay is something that is not extending in proximal boxes. This is something your class 1 cavity, root canal cavity is there, and you don't want to affect your biorim. So you give the overlay to replace your biodome so that it can act as a biodome and can absorb all the stresses. Now coming to the cusp capping. So we have done our endodontic restoration. Now we have to look how much our cusp is there. Already my structural integrity is gone. If my cusp is gone, if I'm not taking care of it, my cusp will also go away. So this study by Veneziani has already said if your cusp is less than 3 millimeter in width, you need to go for an indirect restoration. You need to cap that cusp. You need to give an onlay or an overlay, whatever it is. And how can you measure it? Please buy a vernier caliper and the problem is solved. That is, we used to use in our science labs, physics labs. So, which way to go? Now we have talked about everything. So, this is a summary of what we have talked about. The endodontically treated teeth is already a beacon teeth because of various factors. What we need to do is, if at all we are going towards a direct restoration, we need to make sure that only one of these factors are true. Like either my ICD is less than 50%, either my caries is not that extensive, my crass is within the enamel, or I don't have to cusp the cap the cusp cap. I have to do a cusp cap. Only one of these factors, not all of them. Okay, you have to keep it in mind. If one or two factors are there, please go to an indirect restoration. Like I mentioned, इनमें से कोई भी अगर factor होता है and तो indirect restoration. Similarly, then if there is extensive tooth structure loss, that is only one or two walls are present and rather everything is lost, then we can move to our favorite post and core. So talking about post and core, we all know the what is post. We all are doing a lot of post and core in our practice. And to just emphasize before emphasizing on it, what is a post? A post is a cylindrical rod or a cylindrical structure which is enforcing the strength of the tooth. Okay. So here is one more question for you all people. Okay. What is the function of the post? I have given you four options A, B, C, D. Please tell me what option you think is the best for it. What is the function of the post? Okay. What do you think is the function of the post? Okay. People are saying all of the above. Okay. People who are saying all of the above is absolutely wrong. And people who are saying to retain the core is absolutely right. And people who are saying option C are wrong as well. So the yes, the correct answer is to retain the core. How? Why? Okay. So whenever we are doing a post, what are we doing? We are we are taking the GP out. We are creating a radicular space. We are removing more radicular dentine, and then we are giving a post. So why are we giving the post? Because we do not have a lot of tooth structure present and we need our structure, our core to be bonded. And that is why we are taking support of the post. So what does the post is doing to the tooth? It is strengthening the tooth crown and preventing the fracture around the preparation margin by stabilizing my core. But at the same time, my post is weakening the tooth root because we are removing a lot of radicular dentine. And that is why this is not possible. And the people who are saying option C, please, if you have a lot of tooth structure, please do not do post. If my molar is there, two cusp is lost, two cusp are there, please do not do post. You have still have a lot of material. Please go for an indirect restoration. Why do you have to go for post? Your problem can be solved. Please get a training done and please move towards indirect restoration rather doing a post which is weakening your root which has already been weakened by a lot of things. Here in this article as well, the Perros has said the post should only and only be used for the retention of the core and not for the strengthening of the root. It strengthens the tooth, my friends, but it is not strengthening the root. It is weakening the root only. Okay, moving to the next. So we are doing a lot of post right now, right? But even after that, our post fails. What is the reason? The reason could be a lot. we are applying excessive pressure when we are doing the post. We are removing a lot of tooth structure, and because of that, the functional load that is being beared by the tooth uh, is so excessive that the post cannot actually absorb that pressure, and it breaks and comes out. There are other factors as well, like cuspal deflection and everything. So we're going to talk about all of these by the form how to do a successful post in code. So you need to abide to these rules to do a very good post restoration. We all know how to do a post restoration. We are all aware, but I need to talk to you about this main thing that we all overlook as clinicians. That is ferrule. Okay, ferrule in our from our UG days only, there has been this picture in our Grossman, which we used to write in our paper in a short question answers and everything, but we are not understanding the functionality of this, why it is so important, why we are talking about if there is the post can only be there if the ferrule is there. It is because we have just read this, we are not applying this. So what is ferrule? Let me tell you today in a very simple manner. We all do crown preparations, tooth preparations. So the margin, the amount of tooth structure that is above our margin, crown margin, gingival margin, is our ferrule. It is nothing else. The 360-degree, the structure that you have created is a ferrule. Now, why has been ferrule, named ferrule? It is named ferrule only in the cases of post, where we have to retain core. So that amount of structure which is actually supporting our core is ferrule. Now, there are two kinds of ferrule, and I know I used to get confused a lot. So, let me clear out your confusion. There are two types of ferrule, that is tooth ferrule and crown ferrule. And why are we getting confused in these two terms is because there is no certain good picture to depict it. So, I made it myself only. Your tooth ferrule is the preparation margin that you have made. This is your ferrule, this thing. This is your tooth ferrule. This is the preparation margin that you have made on which this core is now resting. And your crown ferrule is the part of your dental crown, this thing, which will sit together and will give you a bracing effect. It will make sure that your post does not go other way and your crown is going other way. It should work in a similar manner. It should absorb the force and dissipate it along the axis of the tooth. And that is why ferrule is so necessary. Let's see a case where there is no ferrule. Why are we talking so much about ferrule? So whenever there is no ferrule, I apply a force to this. Okay. So Newton's third law, applying Newton's third law to every action, there is an equal and opposite reaction. There will be a sliding reaction from this as well. It will try the tooth to slide, and there will be a rotational motion that will be happening. So basically, what is happening? This is my tooth. I'm applying pressure to it. Okay, so it will move in this direction. Try to move in this direction, because of which my post is there in the long axis. It does not have support, and it will fracture like this. But when we have ferrule over it, like in this picture, we have a good ferrule in this. What will happen is, even if my force is coming, I have a circumference of tooth here and circumference of tooth there. So it is not moving because it has a support. It has a 360-degree band over it. And that is why we need ferrule. Let us understand by this thing. I'll give you an example of maxillary tooth. So our maxillary anterior tooth are labially tilted. Those are not straight. These are labially tilted. Our posterior ones are the one which are in straight manner. So these tooth will face a lot of non-axial forces. Okay. So what is non-axial forces and what is axial forces? Non-axial forces are the forces which is happening at an angle. So this is my maxillary tooth, this is my mandibular tooth. My mandibular tooth will hit my maxillary tooth in this way at an angle. And that is more disturbing forces than the axial ones that is happening along the long axis of the tooth. So let's see what happens when the force is applied. So whenever the force is applied in this direction, the crown that has been given will slide to this side and the post will slide to this side, which leads the disintegration of the tooth. Cut to when we having a ferrule, it will support this core, and whenever the forces are applied, the crown and the post will be in harmony. So we need not to worry about it. So what is ferrule doing? Ferrule is reinforcing the tooth. It is dissipating the force so that it does not accumulate at the narrowest circumference of the tooth. It is resisting the lateral forces that are applied by the post, and also it helps to protect the integrity of the cement seal. So basically, it helps the integrity of the crown. So how should our ferrule be? It should be 1.5 mm to 2 mm high. It should be 1 mm thick in the width. And the taper that should be given to the walls of the ferrule should be 6 degrees or less than that. So in the cases where we cannot give a 360-degree ferrule, we should plan a partial ferrule. What is a partial ferrule? Is like I have a maxillary premolar in which my buccal cusp is not there. Now, how will I? My buccal cusp is not there. It is badly disintegrated. I do not have any structure to recreate a ferrule in it, but I have to give a post. Otherwise, there is no other option. So, what I'll do is I'll give a ferrule on the buccal wall. Your buccal wall is the functional cusp, which will absorb all the stresses. So, the ferrule that I'm giving is still superior to no ferrule, as given in a lot of studies. So, in what cases we can give partial ferrule? In mandibular teeth, please, there should be a structure to give ferrule on your buccal side because those are the cusp that are in most stresses. And in the maxillary teeth, the stresses that are accumulated are at parietal cusp. So for maxillary, it is parietal. For mandibular, it is buccal. If the ferrule or this wall is not there, what are my options? Either I can do extraction, I can do a socket shield and do an implant, or we can try once more. We can do surgical crown landing or orthodontic extrusion. But patient is not going to wait that long. What you can give as other structures, anti-rotational group, but it has not proven very good. It is just theory. What I can do is give a secondary post. We are gonna give two posts. One is a primary post, which is acting the main strengthening of the tooth, and second, just to support the first post. Or what I can do better is, or what I do in some of my cases is, I'll give a post, I remove the GP, I give a post over here, and I'll remove a bit of GP over here, and I'll put all the my composite material in this so that it creates a monoblock effect in terms of post. Remember, in terms of post. So it is having its strength from here as well as from here. Now, coming to post considerations, we all know that we have to maintain an apical seal of at least 4 to 5 millimeter. If we are not maintaining it, how much better we are doing a post, the reinfection can happen and everything can go in vain. The post height should be equal to or more than the height of your crown. It should not be less than that because it won't support the tooth then. The post width. Okay, we have all seen this picture in our books. The first one representing the conservationist approach, the second one the preservationist, and third one is proportionalist. So, making it all simple for you, please use the smallest possible post that is binding to your tooth. Please do not assume that I have a number two post that will provide good strength to my tooth. So I'll use a number two post and remove more radiculodentine just to fix that. Even your number one post is gonna give you the same strength like your number two. But please do not remove radiculodentine. Yes, if it is very loose, your number two is fitting well, you just need a little correction, then that is fine. But if you have to remove a lot of radiculodentine just to fix that, please don't do it. Okay, now what should we go for? Whether the custom cast post is good, whether the prefabricated is good. The custom cast post is actually very good in large canals or oval canals, but then there is a lot of lab cost which is associated with it. Also, it needs a multiple setting, which patients are now not very comfortable with. They want the work to be done in that one setting. So yeah, custom cast posts, you can do. It is very good. It is till now the best procedure, even with the prefabricated post. But yes, now if we are shifting to something which is more reliable, we can go with the prefabricated post. There are a lot of materials like Ribon Endo gives, or that the Dentapreg people are giving, in which you can use that ribbon-like post, and you can use in these large canals, oval canals, where your cylindrical post is not working. Prefabricated post, yes, almost all teeth. Prefabricated में आता है metal and fiber. In metal post, we get the strength, but these do not flex. A lot of prosthetic people are doing, still doing metal post. A lot of people are doing. I am not a very big fan of metal post because of a lot of reasons. We are luting this with GIC, which disintegrates with time if there is a slightest of leakage, and it does not flex as well. So it is not dissipating the force, or it is not acting like how our dentine should act. The second thing is the fiber post. The fiber post is low in strength, but it flexes with dentine, behaves like dentine, but it is not dentine again. But yes, this is the best option that has been there from years. Now, what should be the surface of post? So please do not use any post which acts like your nail. That is, you are screwing it in the dentine. You can lead to micro cracks then and fracture later on. Please use smooth or surface treated, or serrated will also work, but use a smooth or surface treated post which adheres with dentine very well. If you are gonna screw in your post, then you know what happens. Now there are different configurations of the post, that is parallel, tapered, and combination. Yes, the combination one is the best one because it will give you good retention as well as good strength. What are the contraindications of the post? These are the contraindications. Yes, where there is a severe curvature, you cannot use because the root will be at a different angle, and the forces that will happen along the long axis of the tooth will cause the fracture from that curvature part only. Then there is obviously persistent. If there is a persistent infection, you won't be doing it. Third thing that I have already talked about in the start, that is why you need to take care of your periodontal health. If that tooth is not in a good periodontal health, you cannot and will not be able to save it from any post or any crown or any good indirect direct restoration. Then poor crown to root ratio, where our roots are short and we do not have good crown structure, we cannot give a post because it will not adhere to it. We can look for some other treatment plans, like now we have good DentaPreg meshworks. We can do that, or we can uh, do certain kind of splinting, but not post is not meant for this. Teeth with heavy occlusal contacts, economic factors, inadequate skills. But the biggest contraindication for post is if the tooth structure is present. Please assess it properly. If the tooth structure is present, you cannot and should not give post. You have to assess that. Not every teeth requires a post. Not every teeth is a money making process. You will make money, but again, you're actually dealing with something human. These are somewhat cases of in which you can use post because the structural integrity is not well, and we have good ferrule as well to give. Coming to what should we lute with, we should not lute with our bulk fill composites, our light cure composites, our GIC, RMGIC. What we should do is use of dual cure composites. Why dual cure composites? Okay, there are two reasons. First reason is the dentine of the corona. The coronal dentine is very different from the radicular dentine. It is more porous, it is more watery, and you need something to set on its own. You do no need to. You do not need a lot of polymerization shrinkage whenever you are doing it. Second, your curing light will not go through your canal. It is very narrow. Maybe your curing light will not reach that end point of the post, and if it does not set, it will create a problem. So you need a dual cure materials that sets automatically by its own, even if we are not light curing it. Then there are some new advancements which I am very eager to learn, and maybe I'll be learning in after sessions of this. That is a post and core which is made up by Edelweiss. Now, this post and core is actually a biomimetic post which is made up of composite, and they have been manufactured laserly sintered as uh, as a it has been lazily sintered, and the structure has been made like this so that the modulus of elasticity is compared to the dentine. It is the same, almost the same. So that whenever we are using this, it acts as a monoblock effect, and the stress that are dissipated in this monoblock effect are be more uniform and provide more strength. So yes, this is a very good option for doing post and core. Then is this DentaPreg mesh, which I'm very excited to learn about. This is a mesh that has been created with a fiber reinforced composite material. What is happening is whenever we are giving a force to a tooth, the inner layer is in a lot of stress, and that is why we need restoration somewhat that absorbs the pressure, that absorbs the stress. When we applied this DentaPreg on our tooth, it absorbs all the stresses and then it dissipates to the tooth structure. So what we can do is we can use this DentaPreg in terms of those cases in where we have low crown height. In the cases we want orthodontic extrusions, so we can use this so that this layer can help us to form our structure and provide strength as well. There are different enterprise which are available. This is SFM that are used for your splints. Then this is SFU, which are used for your crown splintings and as well. These are used as a PFM crowns. Then there are pin and post. So a lot of DentaPreg post. And the great thing is they have different types of DentaPreg materials according to the indications where it is needed. So a similar one is not indicated for everything. Now coming, we all know how to cement a post or how to bond a post. And let me just give you a brief. We'll remove a gutta percha. We'll leave 4 to 5 to maintain the marginal integrity. And we will enlarge it with the piezo reamers or glades hidden. And we'll make the final post preparation with the drill specific post only. Then we'll treat our dentine, we'll treat our post, we'll put the luting agent, we'll form the formed core, and that is where we are done. Now, troubleshoots. What I have seen people face is the first thing is whenever we are placing this post, the single post can create a lot of problem because of the dentine that is present, because of the C factor, that is the ratio of bonded to unbonded. So whenever this is a post and there is a lot of space present, it can lead to your polymerization shrinkage. How can you overcome it? You can overcome it by using two technique. That is, first one is the secondary post I have talked about, or if there is a space for secondary post, you can use a smallest post and it will work as your secondary post. Or what you can do is you can do a delayed polymerization. That is, you have kept your material, dual cure material, you allow it to set for 2 to 3 minutes, and after that, you light cure it so that the initial polymerization has already happened. Second thing, whenever you are doing a post, please, please remove this GP on the walls. Otherwise, your adhesion will not take place. I have seen a lot of cases in the which the post is there, the gutta parcha is also there. If the gutta parcha is not there, the sealer is there. You have to need to clean the chamber to make the space for the post, and for that you can use your sodium hypochlorite, your best friend. Also, please use post-specific drills. Don't go for just piezo reamers. Piezo reamers is something what makes the space, but they are not drill specific. So, what problem does it causes? You have prepared a space with two number piezo reamer, and then you put your number one post, but there is a gap between the gutta percha and the post. Why is it happening? Because you have not used specific drills for the specific post. So you need to use that so that the space is created is according to the post, and you don't need to remove a lot of material to accommodate the post. So there is this video that was by given on YouTube by Dr. Rohit. So I would like to show you this so that you can know what is done in regard to the post. The post space is prepared by removing the dentine by using piezo remover 1, piezo remover 2. Then an specific drill is used to cement the specific post. The post was tried, and yes, just because we are using a post specific drill, it can be cemented very well. What I need to show you is here that please cut your post with a burr or with a disc only. Do not cut it with a scissor. Why? Because when you cut it with the scissor, it takes a lot of effort, and the fibers, post is nothing but a fibers, mesh of fibers. It will open up, and then it will cause micro leakage. So you need to understand, please do not cut it with a scissor. Please cut it with a disc or cut it with a burr. Here also they are doing etching of the tooth. I'm so sorry, but that is not what I do. I use my dentine conditioners. I do not etch. Why I'm not etching is because all we are doing our cementation is in dentine, and we know how etching can actually destroys our collagen, collagen that is present in dentine, and it can actually disintegrate your bond. So yes, I do not use etching. I use conditioners, which very well can work with dentine. Then you can remove the excess moisture with a paper point. It is very necessary to remove the excess moisture, and that can only be done with a paper point or with an aspirator as well. You can do it with an aspirator as well. They have used a prime and bond NT and self-cure activator. They have applied it. Okay. Now they are applying the bonding agent. You would need a thin applicator tip. Your normal applicator tips won't work in these kind of cases. So these are small, small things you have to keep in mind so that you do not have problem in your clinical practice. While they are moving it along the dentine, we need to scrub or we need to apply it for 20 seconds or according to the manufacturer, whatever they have told. So they have removed the access bonding agent with the paper point as well, so that it does not create another thin film line. After that, they have cured it. We are gonna put our cementing material, that is fluorochlor in this case. Then we are gonna take our post. Before the post cementation, I will be treating it with saline coupling agent so that this is a surface treatment for the post. Every post has a different surface treatment. You have to read your manufacturer. Please जो manual आता है साथ में पढ़ो. When we are light cure it, we are gonna add increments, and that is how our post and core is done. Okay. So yeah, we are done with a very extensive post-endodontic restoration. Thank you all for your time and participation. And always, always remember that the success of endodontic treatment does not end at obturation. You have to restore it well. You have to make sure you have done everything in a right way. Let's apply this knowledge into our dentistry tomorrow onwards, and let's have a good dentistry. Okay. At the last, I would like to thank these people. These have been a building, like my growth builders. They have been there with me learning. Dr. Anu is there, Dr. Manisha is there, Dr. Ashima, Dr. Shutika is there. They have been a very good batch of people who have with whom I have learned a lot of endo. And lastly, my family who has been there as a pillar, and they have like I have ignored their calls for this presentation for my work, but yes, the family is the pillar. Like in the post endodontic restoration, your good restoration is your pillar. So yeah, thank you.
Thank you so much, ma'am, for this insightful lecture. We actually have few questions if you would
Yeah,
like to
I
answer
am
them.
ready. We'll be starting from ups. Okay.
Yes.
Okay.
There's a Question by Dr. Dilip Das. In case where minimal coronal structure remains, how do you decide between fiber post, metal post, or endocrowns? What are the clinical criteria for each?
Okay, we have talked about it, Dr. Dilip. Just one second. Let me read your question by myself as well. Okay, so I have already told you ki are we gonna decide until and unless there is just one or two walls left, you are not gonna go for post. Please do not go for post. Please kill yourself. Please train yourself in indirect bonded restorations. These are beautiful restorations that I am also learning and working. So I won't comment on that. Even I am in a learning phase. I am in always in a learning phase. So whenever there is minimal, to answer your question, whenever there is minimal tooth structure, you have to assess all these things that I have told you. Okay. Unless and until there is a structure which is very less, like I have told you, one wall is present and there is no indefinite crown structure, then you'll give your post, then you give a good endodontic restorations. Regarding the endocrowns, endocrowns you can give in those cases where the clinical height, like the crown height, is very less. So you can take the support from the endo chamber and you can give the crowns. But now a lot of partial indirect restorations are there. You won't be needing endo crowns. But still, if the clinical crown is less, clinical crown se mera meaning hai if the biodome is not there. Understand the concept. If the biodome is not there, only the part of biorim is present, and you need to reinforce that. Then you can take the support of your endodontic cavity and give your endocrown on that. It is good. I am not telling it is not good. It is good, but you have to decide for each case how you can. Endocrowns is mostly given in mandibular molars only because that is where the most problem happens. But you can give it in any of the molars. Next question.
It is by Dr. Anthony. For endodontically treated interior teeth, how do you balance aesthetics and strength when choosing a post and core system?
Okay, Dr. Anthony, I have answered that as well, but let me try to answer that in a more clinical way. So, if we are dealing with an anterior tooth, we have to go all in all aesthetic. We cannot use a metal post, we cannot use a custom cast post nowadays because people won't appreciate that well. Because if we are giving a custom cast post or a metal post, we have to give a PFM crown. Otherwise, it will show from the zirconia because we use a layered one. And in the cases, we can use the Emax as well. And Emax crowns, it will be visible. We cannot give Emax in those cases. Layered ones might, it might happen that it is showing, if the crown structure is so much at loss, it can show through that crown as well. So we need to understand that in those cases, we cannot use a metal post. And regarding that, what post and core system? There are numerous post and core systems. It is by 3M. There is one by Avview. You can use any of the post. Yes, as I have told you, use a combination post which is parallel as well as tapered. And now you can go for this Edelweiss post as well, which creates a monoblock effect. I am going to use it in my future. I would like to see how does it do well with the tooth, and I'll get back to you. कि कैसा रहा the experience, how was the experience, how was everything.
Thank you. Next question is by Pankaj Rao. With the rise of 3D printing in dentistry, do you see a future where dentists can 3D print custom posts directly in the clinic? What are the current limitations for it?
The current limitation is the expense. Let me get straight. Yeah, the thing is, the first and foremost limitation is actually the expenditure. First, we need to have an intraoral scanner. If we have an intraoral scanner, then we have to have an in-house lab where the intraoral scanner, that is the CAD design, which we have designed for the patient, can be converted to a CAM design. That is, we are manufacturing it inside the clinic. Look, if we are sending this to a lab, there are very okay. We receive crowns from our lab. In 10 of the crowns, 2 crowns are there which will not fit. How can we rely on that lab that they will make a good post? We actually need to, yes, with future we can do it, 3D printing we can do it, but yeah, the cost is very high. You won't pay it, the patient won't pay it. Even if everything falls into the place in terms of expense, nothing is stopping you. Please do it. please do it in your clinics. It will be beneficial for everybody, because this will be something that is very much similar to the structure that will help you. But I think the Edelweiss post, let me use that. I think that would be better, because it guarantees it has a monoblock effect, and they are not new. They are doing their thing from past 10 to 15 years, and they have long uh, cases and long literature about that. So yeah.
Next is by Mohit Gautam. A 42-year-old patient with a history of grinding their teeth bruxism had a root canal on their maxillary premolar 6 months ago. Now they report pain when biting down. On examination, you spot a vertical crack on the buccal cusp. How would you manage this case? Would you go for full cuspal coverage? And if so, which material would you choose?
Very nice question. Okay, and I like clinical based question, because it actually lets me also think in that kind of scenario. So the thing is, there is no other medical condition that you have mentioned. Yeah, yes, he or she, whatever is a bruxer, and there is a vertical crack. So you have to dissect the crack. What is gonna happen is, whenever you see a crack, please start removing it. Okay, if you're not able to see it in, okay, first before removing it, please do your analysis. See, take a radiograph. If it is not visible in radiograph, take a CBCT. If the patient is um, not convinced for the CBCT, please you get you get a CBCT at your expense. If also for not that, then you dissect that crack. Start removing it layer by layer, and see how much it is extending to. If it is extending to below the level of CEJ, then it is a of no good prognosis. Please extract it. Please do an implant. That is of no use of keeping it. We cannot restore it. If it is above the level of CEJ, if it is dentine, like I have said, okay, you can give an indirect partial restoration. If it is in enamel only, please give a direct restoration, a good composite. By good composite, I mean please replace it with a dentine material, like there are SDR, there is Everex, which is a fiber reinforced composites. Then give your enamel layer, that is by your body composites or any kind of high strength composites. So yeah, that is how you'll manage the case. I will not go for a full cuspal coverage till then. If the crack is from buccal to lingual or buccal to palatal, I will never give a full cuspal coverage. If it is extending from buccal to lingual, then only I will go for a full coverage crown. Otherwise, if it is on the buccal side only, like I have said, dissect the crack. Where is it going? Where is it traveling to? If you're not getting any kind of examination done, you have to do it by yourself then. Dissect that. If it is not traveling buccolingually, don't give a, if it is extending buccolingually, give a crown. If it is not extending buccolingually, it is on the buccal side only, please give a partial indirect restoration. It can be your overlay, and it can be your crown lay. So basically, partial indirect restoration does not have, that is why I'm telling you it is a separate webinar to talk about. Partial indirect restoration, like I'm telling, crown lay, overlay, does not have a specific term. It is whatever structure we have. Please save that structure and give the indirect restoration over there. So हम कितने भी नाम बुला रहे, indirect restoration does not have a specific thing. You just have to maintain some rules that is required for indirect restoration, and give those indirect restorations.
Next question is by Dr. Pratika. While preparing a post space in a previously treated maxillary canine, you notice a small perforation near the coronal third. What do you do next? Can this case still be salvaged? And if so, which materials and technique would you see?
Okay. First of all, if we are doing it and then we are getting that buccal perforation, we have not read our X-rays very well. Because in a canine X-ray, it is a bulky tooth. We can see very nicely that there is some problem with the tooth. So please read your X-rays very well. Second thing is, maybe you have not not you, but yes, some doctor has not removed the caries that I have talked about, and that is why the perforation is there. Or while doing an endodontic cavity preparation, they have gone to another direction, which can lead to the perforation. We first need to know why the perforation is happening. So whenever you are preparing a post space and the perforation is there, please inspect the perforation. Okay. If you think the caries is there, please remove the caries. If you think only a perforation is there, so no need to worry about it. If it is small, you need no need to worry about it, because when you are giving your post, the material will seal that coronal perforation. That perforation will be sealed with your material. But if the perforation is huge, okay, you need to see if there is any crack or not, because if the perforation is there and it is long standing, micro cracks can be there. And if you have given a post and you have not seen that thing, then that will create a problem. So you need to assess that perforation. If it is small, the cracks are they if it is small, go ahead, you no need to do anything extra. If it is large or medium, you need to see are there any cracks, caries residue hai, hatao usko, and the post will be done in the same manner. uh, Now if I talk about ferrule, you can give ferrule. You need to assess whether you have the coronal structure inside the gingival margin as well to give your ferrule or not. Okay. So you have talked about small perforation. No need to do very rocket science in it. You can go ahead with your procedure. Then when you are preparing your crown, you can manage that very well.
Okay, and we have a last question by Dr. Prateek. A young patient with a root canal premolar stress analysis suggests that an onlay restoration would be sufficient. Do you trust AI-driven recommendations for minimally invasive restoration, or do you prefer conventional full coverage approaches?
Okay, let me read that once again. A young patient with a root canal premolar stress analysis. Young patient, okay, I hope it is not a kid, because kid does not have premolars. A young patient with a root canal premolar stress analysis suggests that an online restoration would be sufficient. Do you trust AI driven recommendations or minimally invasive restoration, or do you prefer uh, conventional full crown approaches? That okay, stress analysis. I will always take consideration of stress analysis, but what I will take in consideration of all that things that I have told you today, that whether my intercuspal distance is that good or not, whether my caries are extended to it. I know what you meant by stress analysis, that if we are applying pressure to if the functional stresses are that much, we should always go for an indirect restoration. So I won't go for a direct restoration. But yes, do I want to go for a full coverage, or do I want to go for my only restorations? If the stress analysis is there and it is already in occlusal load, I have already told you, if the my cusp is in tensile stresses, I will cusp it, I will cap it, and I will give an indirect restoration. But after that, what design I'm gonna give is totally dependent on the factors that I am looking at. That is caries, cracks, intercuspal distance, my endodontic cavity. That will all depend upon that. So if a young patient who has this thing, I will not go for a full coverage crown, because I have to save that biorim. That biorim is very important that we remove for a crown. I feel bad now for my patients, because I have this knowledge that removing biorim is destroying the tooth, and then I have to do that. It is very saddening, because some nobody has asked me how can you convince a patient for an indirect restoration. It is very tough to actually tell them, because a lot of people won't need that restoration. They will say ये तो अधूरा crown है, because everybody that is entering to your clinic, they do not need a root canal treatment, they need a crown. And you have to make them understand कि root canal therapy क्यों important है. ऐसे ही you need to make them understand कि indirect restoration is what saving your tooth, saving the integrity of the tooth. So yes, for a young patient, I will never do it. Old patient, yes, so never, but young patient के लिए भी I will never do a full coverage restoration. I will go with indirect restoration only. Or if the stress analysis would not have been there and everything would have been fallen into the place, I would have done a very good direct restoration, but not full crown restorations for an individual.
Okay, and last one by Dr. Anu. Tell a brief about how you are managing contact and contour in your clinical cases, because they are doing amazingly.
Ma'am, practice. I am a student and I have always been a student and I'm always gonna be a student. What I have done is I have made mistakes. And so don't be scared of making mistakes. I have made mistakes. I know where my contact and contour is not proper. I see cases done by other clinicians. I see how they are applying the wedge, the matrix band, and everything, what matrices they are using. So in the world full of Toffel Myers, we have a lot of matrices. We have saddle matrices, we have Paladin, we have Garrison, we have a lot of matrices system, and the correct way is not to use all of them. We should just know what to use where, and that मैं कितना भी lecture दे दूं, I can give a lecture on that as well, but that comes with practice. I use my saddle. Mostly I use how I do it. Let me tell you, I use rubber dam isolation. That is go. No rubber dam isolation, no cavity prep. Especially the proximal ones, that disturbs me a lot. In my PG life, I was very much threatened with the proximal restoration because I was not using rubber dam. Your rubber dam seeps reduces a lot of seepage from saliva, from bleeding, from your gum. You can pack the Teflon, like Dr. Manisha said last day. You can pack the Teflon very well, and it will help you a lot. So what you need to do is, what I do is, to acquire my margin or to do a deep margin elevation or accusation, I use my saddle matrices. After that, I'll see whether I require that saddle matrice to form my contour, or whether I require a paludent or some other matrice to form my coronal contour. Okay. Also, whenever you are filling a cavity, whenever you are doing a cavity, when you are done with the cavity, please give a bevel to it. If you're not giving a bevel to it, the margins would be at a knife edge and it will show and it will crack from that position as well. So, yeah, a bevel, a good matrice, rubber dam, absolutely will do wonders. And practice and practice will make your life very easy. So, yes, thank you, Dr. I know. Dr. Vishakha, is there anything else?
Okay, sorry for the glitch I had from my side.
No problem.
And thank you so much, ma'am. It was a very insightful lecture and presentation by you. And it's definitely gonna help us in like maintaining the tooth structure as well as the functionality for the same. And we are definitely gonna use your knowledge to our clinical practice as well. And thanks all to the participants who are actively engaging for the lecture for today. And all of the lectures happened like before also. And also, we would like to extend our like heartfelt gratitude to the medical aura community for providing us with the platform to learn, share, and grow. And thank you for your dedication for promoting knowledge sharing, collaboration, excellence in medical field. And we will look forward for more collaboration as well. And thank you so much. Thank you, ma'am, again.
Thank you, Vishakha. Thank you so much.